on the top, Dr. Park, Sean, and Minek Knights, and everybody. I hope it will be a good evening, and I hope you will enjoy it.
Everybody's hoping as well, so please do your best. So as this event is live, we will collect all of your questions during the presentation of Dr. Partiyan. We'll answer them at the end of the session. But also, if you have a will to chat live with Dr. Artis, so please don't hesitate and just raise your hand or text me in a Q&A session. Then I would like to have a live chat, and I will make you able to do that. So no problem with that. So Dr. Partiyan, let me hand you over, and the stage is yours.
Thank you very much. So let's begin. Countdown planning in aesthetics and implant dentistry. So why I chose this topic? Because recently we are talking about prosthetic importance of the prosthodontic treatment planning before doing any procedures. Me as a prosthodontist, I always wanted to do the planning taking into consideration the crown first. During my presentation, I will, my argument I will prove, and I will support my argument as much as possible. So as Rolandas told, I am Hrayr Partiyan. I am prosthodontist implantologist. I am instructor in fixed prosthodontics in my faculty, Beirut Arab University. I am also photography course coordinator in Beirut Arab University and Lebanese University. And I am Minek Knight, which is I'm active member giving lectures here and there. So the learning objectives in this presentation will be to do interdisciplinary planning in aesthetic and implant treatments. I will emphasize to know how to do interdisciplinary planning, because we can do interdisciplinary planning, but the planning itself is not enough. We have to know how to execute it by knowing the materials, the techniques, and not we alone. We have to have a good team. The team that includes us, our assistants or associates, and the technician at the end of the procedure. Second point I will talk about is how to use the recent available materials and techniques to have fast and accurate results. And the third point is to use current technology aids to plan and execute procedures following the ideal guidelines in aesthetics and function. So the subjects that I cover in my lectures are full mouth rehabilitations, anterior aesthetic indirect veneers, interdisciplinary treatment planning, anterior immediate implants, and zirconia full arch restorations. My thesis was on zirconia back in 2008 and 12, till 12, I finished my research. But today I will talk interdisciplinary treatment planning, but mostly I will emphasize on anterior immediate implant placement, or not immediate, but anterior implant placement. I will have a quick review on interdisciplinary treatment planning, showing you a very brief case. Before starting treatment planning, we have to collect data as much as possible from the patients. And data collection is very, very, very much important. As much as we have data, as much as we are able to know and to see the options that we have in order to do the perfect treatment. So we have photos, we have x-rays, study models, digital models, CBCT, intraoral scanners, video analysis, and smile analysis. In the past, we used to focus on biology, the gums, the health of the tissues, hygiene. Then we were focusing on supportive structures, posterior crowns, inlays, or veneers. Then the function of the maxilla and the mandibular, if they are in their centric relation or not, if they are in good occlusion or not. And finally, the aesthetics to improve the incisal plane, color, shape of the anterior teeth. But nowadays, we shifted a bit. We have put the aesthetics at the front. With the aesthetic endpoint determined, we established a logical sequence from biology and support, incorporating the required functional parameters without forgetting, on the contrary, by respecting the biological limits and timing. So this is very much important. And this was my plan how to work, plan of working since the day I graduated. Because before I graduated, I had always in my mind that I must not start any procedure without visualizing the final result. And why I said before graduation, because here I want to thank my first mentor, my father, whose factory was my childhood playground. Here you will see a bending machine, a metal bending machine. So my father used to tell me, before doing anything, before you design anything, you must know what materials you have, what machines you have, and the technical support that you have in order to finalize your work. So let's come back to our dental subject. So we collect data as much as possible. We put on the software our comments, and we send them to the technician and specialists. This is called interconsultation, that we must not do the things alone. We must have the help of our specialists and our technicians, which in their turn do their specific remarks on the data that we collected and the procedures or the final treatment that we have in mind. So the treatment planning must be done based on evidence. We must rely on the skills of the clinicians and the lab technicians. The third, which is one of the most important pillars, the patient's needs, wishes, and commitment. Because as much as they wish to do things, they must know their limitations, plus they must commit to the needs or to the wishes that they are asking from us. So this patient named RP, she wanted to have straightened teeth and a very beautiful smile. So what we did, we collected the data, we took photos, the classical interpupillary line, which must be parallel to the floor. We drew the midline. We identified the smile line and the incisal curve. We took the intraoral photos and we put our diagnosis. And then we sent it to the orthodontist, who in her turn sent us her feedback and her way to treat the crowded teeth. So the treatment planning, we fixed it and we presented it to the patient. First, we told her the problems that she had. We explained to her the current condition. We explained probable consequences if the treatment was not performed, not only for the anterior crowding, as well as the posterior teeth where we needed to have implants. Emphasize the benefits if the treatment is executed immediately. Ask the patient if she's interested to know how to be treated, because sometimes they don't like to hear anything, but they want to have assurance that the way they will be treated and the final result will serve them for at least more than 10 years or so. Present the treatment options according to the priorities, explain the concerns, limitations, compromises, and elaborate the treatment plan considering patients' preferences. So the treatment planning, the second appointment, we present the patient with the mock-up, how we are planning her teeth to look like. And we take photos and present it to the patient. So everything that is explained before is education, and everything that is explained later is sounds like excuse. So everything we have to tell the patients before doing anything. So this is a short review for the interdisciplinary treatment planning. Now I will talk about anterior immediate implants. The first case that I will present, I will talk about 4 cases, maybe 4 anterior cases, but in between I will talk about 2 other cases to cover my subject fully. So the first patient, his name is Musti Sa'a. He's from Lebanon, but he used to live in United States and Qatar. So he had a problem in his front anterior tooth number 21. You can see the radiolucency. Back then, the referring doctor, he didn't want to take CBCT, but thankfully I had my Megagen implant with me. So I extracted the tooth. I found out that we have no buccal bone at all. So I put the implant, almost floating, not to say 100% floating. Then I put fuse abutment. Later in my presentation, I will focus on fuse abutment, and I will tell, for those who don't know about fuse abutment, what is fuse abutment and what are the advantages of fuse abutment. Then I put the temporary. The temporary, I fixed it with the neighboring with composite. I did etching and bonding and flowable composite. So the patient then temporary crown, filled the bone defect with deproteinized bovine bone material, and then I covered with collagen membrane. Day 1 of the surgery, after 1 week, after 8 months, and after 8 months, I did a mock-up and I put almost the final provisionals, sent the impression to the lab. I took the impression with polyether. Then I took the shade. I take all the time, I take the shade like this in order for the technician to know the underlying structure that he will deal with. Maybe we have discoloration, maybe we have more darker teeth. So he has to know the condition of the the current teeth or the prepared teeth in order to know what kind of material to use, or better, what type of coping he has to use, either light opacity, medium opacity, or high opacity material. So I took the impression and sent to the lab. Here are the final provisionals. Here we used zirconia abutment. It is prepared by the technician. And on the top, we have Emax. Here you will see the, after cementation, the crowns. This is in 2015. That is after almost the end of 2015, because we waited almost 8 months to take the impression. So last week, the patient was not here. Last week, after 5 years, the patient came back, and Here is the condition inside his mouth. Now, sometimes dentists, they say, how did I put the implant in that condition where there is no bone at all supporting and there is no primary stability at all, zero stability? It's not that I wanted to do heroic work. I know what I am doing because I know the material, the implant that I'm using, and the xenograft that I used, that I mixed it with scraped bone that I took from his maxillary posterior area, where I know that I will have perfect result, especially in the stability of implant. How? Because the macro design of the implant in this situation is very much important, because the distance between the flutes is very much important, plus the depth from the core body of the implant and the extremity of the flute itself. So this area, vertically and horizontally, it's an important container for the blood to form bone. And this will give us stability for the long run. Plus the knowledge of the stability that we can achieve with knife threads with the Enrich implant, where we have almost plateau stable stability from day 0 till 10 weeks. And this is a case done by Dr. Han, where he put 9 implants and he checked them periodically every week. And with ISQ, he had almost stable results throughout 9 weeks. So after knowing the macro design, as I told you, my mechanical way of thinking goes back to my childhood. And the implant system is only mechanical system, because the biology, the mechanics in biology is so much different in mechanics, in the mechanical engineering, as well as in implant dentistry. So as you see, it almost passed 5 years and we have very stable result in the gum. So the second patient, his name is Prince. He had again tooth number 21, which was fractured. So I extracted it, I put the implant, and then I put the fuse abutment. What is fuse abutment? Fuse abutment, it's a temporary abutment manufactured by Megagen, which is very safe to the implant. So from where the concept fuse abutment came? Fuse abutment came from the electrical fuse, the concept of the electrical fuse, where we have when we have high voltage, so the fuse breaks, and when the fuse breaks, it protects the main engine. So in this case, the main engine is the implant. So how is this done? We have the metallic part of the fuse abutment, and we have the plastic part attached to the metal connection. So in a study done by Punsky, he found that osseointegration will fail if a newly installed fixture is forced to move. How much force and how much movement? So 100 micrometer movement we result in if we have 220 newtons of force. So by in vitro testing done on fuse abutments, we found out that below 200 newtons, the plastic part detaches from the metallic part of the fuse abutment, as you can see on the graph. So advantages of the fuse abutment is that it protects the fixture by breaking itself. So here is a small video showing how the fuse abutment works. We first fix the implant, then we fix the fuse abutment on top of it, and then we do the temporary crown and cement it. And during the function, if we have forces exceeding 180 newtons, the plastic will detach from the metallic part. In this way, we will protect the fixture. So direct provisional over the implant at the day of the implant insertion. After 2 months, the healing of the gum, ISQ value 80. Aesthetic planning. So first, our concern was tooth number 21. Then the patient wanted to have full upper arch rehabilitation. So we did the planning. In the past, we used to do wax up. We used to take impression and we used to do wax up. Nowadays, we are doing it in a different way. At least I am doing it with my other mentor, Dr. Galip Gürel, who has created something called the Rebel. The Rebel system is a software where you take the impression and on one of the anterior teeth, we do a composite mock-up. We take data from the patient. We take 5 photos. We upload the photos in the software. We do a special interview with the client. In the interview, the computer, the algorithm in the computer itself gives us the type of the patient that we are dealing with. So face reading gave us dynamic, delicate, and calm nature of the face. Then with the questionnaire, we ask specific questions that mirror the patient's psychology. And based on the algorithm itself, the computer or the software gives us a proposal of the design of the teeth that we must have. Here we upload the 5 photos after the interview. Then we mention few points. Then we take the scan of the upper jaw and we send it to the lab. So intraoral scan of the patient, upper jaw only, with a single mock-up on the central, just to indicate the incisal edge position. So then the computer sent us the preview and we print from the software the suggested design and we transfer the suggested design into the patient's mouth. So the other case, now I will shift to the iGen, which is another product, which is one of my daily used products, other than the fuse abutment. In this case, we had a deciduous canine. We extracted the deciduous canine. I put again the N-ridge implant, which is almost floating, 0 stability. I put xenograft. So here I will explain the concept of iGen for those of you who don't know it. So when we put the implant, we need at least 2 millimeters of bone surrounding the implant. In the cases where we have gap or no bone at all, these are the articles by Nozawa and Uli Grunder, where they mention the dimension of the bone needed in order to have perfect results and perfect prognosis for the future. So from the buccal side, we need 2 millimeters of bone. So what we do with the iGen, which is a titanium membrane fixed on the implant, and it gives us more than 2 millimeter space, 2.5 millimeter space, in order for us to load the area with xenograft. And then we cover it with the iGen membrane, and then we fix the iGen membrane with iGen healing cap. After waiting almost from 4 to 6 months, we remove the iGen, and we will have, of course, resorption of the grafted bone. We will have almost 2 millimeters of bone on the buccal side of the iGen. Here is a small diagrammatic video. It shows us how we use the iGen to increase the thickness of the bone at the implant site. So if the implant diameter is 4, we need 2 millimeters from the surrounding in this case. So we fix the iGen and we put the bone and we wait. And after 4 to 6 months, we remove the iGen. In this case, I put it, as you can see, and covered it. Collagen resorbable membrane. And then suturing. After 7 months, I exposed the healing cap of the iGen. I removed with the holder. I checked the stability, 74. Healing abutment. We were not happy at the position of the gingiva, so we did soft tissue grafting on the buccal side. We put Megagen, we sutured it, we waited for another 2 months, and after 2 months, we took closed ray impression, PFM over the implant, and this is the final result of this case. This case, this is, for me, it's one of my most important cases where I did some modification. Now you will see, and this is the first time I'm sharing this case with you guys. In 2015, again, it was mid of 2015 when I finished the case. No, end of 2015, I finished the case. I began the early 2015. We had to extract tooth number 11. And again, we have defective bone. So again, knowing the mechanical properties of the implant, the biological properties of the implant, my limitations, patient being perfect candidate, non-smoker, no bad habits, bite or etc. So I fixed the implant. I filled the bone defect with deproteinized bovine material, xenograft. I put the iGen and I fixed the fuse abutment on top of it. I did some modification at the hole of the iGen that is fixed on the implant, because the iGen's opening that fixes on the implant is small. So I increased the diameter and then I fixed the fuse abutment on top of it. Because I know that the implant is stable and the iGen will hold the bone material. In this case, I couldn't leave the patient without a temporary. So we need the temporary. First, I made sure that I have primary stability. Then I supported the bone with iGen. And then on top of it, I put my fuse abutment. and then I covered it with collagen membrane and sutured it. After 1 week, this was the case. After 4 months, removal of iGen, we waited a bit, and then after 2 weeks or 3 weeks, we took impression. This is a zirconia abutment. Here I did, again, a small modification. Here, if you can see, we have the zirconia abutment. But the finish line is a bit low under the gum. So because I was going to do a cemented crown, I wanted the finish line to be more coronally placed. With this abutment, I am not able to do it. But of course, with customized zirconia abutment, we are able to do this. But what I did here, I did Emax collar, and I cemented the Emax collar on the zirconia abutment, and then I fixed the abutment inside on the implant. After fixing or after torquing the abutment on the implant, I cemented the crown. It was in end of 2015, I cemented it, and this is 2020, follow-up after 5 years. Here, you will see some defects in the gingiva and the tooth number 12, and on the buccal side of the implanted tooth. So I suggested for the client to remove the ceramic and to redo it, and by reshaping the abutment again. So this is the past of the photography. This is the first SLR camera in 1936. And this is a very recent digital SLR camera. We have too many options in the new one, else in the other one, we could only take photos. This is the first computer, Abacus. This is Alan Turing's computer, decoder. And this is the first known computer, the IBM. So the mobile phones now have options much bigger and larger than the computers in the past. So the world is going to digital in everything. So why not dentistry too? So the scientific literature agrees that the implant prosthetic rehabilitations have a 5-year survival rate of approximately 95% and greater than 89% after 5 years. So the current trend in implant surgery is to further improve the clinical procedures by less invasive surgical techniques. So here, recently, to minimize the chair time is becoming very much important. But from the first day, it should have been our main topic, to minimize the chair time, but not on the expense of the patient, but not on the expense of the client. Now, because of the corona and because of the digital dentistry, we are talking about minimizing chair time, but it was the plan from day one to minimize the chair time, at the same time to deliver high quality service to the patient. Guided implant protocols, according to the article, say that they could help clinicians to simplify their procedures starting from the diagnostic phase up to the realization of the final prosthetic restoration. The diagnostic phase, that is the impressions, digital impressions, intraocular impressions, CBCTs, 3D X-rays, and up to the realization of final prosthetic restoration, that is the prosthetic part that is done by CAD/CAM, etc., etc. So what I am using in my clinic is the Artgate. Artgate is the software created by Megagen to do computer planned or computer guided implant surgery. I mentioned this in February 2019 in Dubai when I said it is not computer guided surgery, it is still us who are doing the planning. So it is from our experience and our knowledge that we are planning the case or the implant insertion by using a specific software. And this specific software, in this specific software, we are determining the position of the implant by having the crown position in mind and the occlusion in mind, and then by fabricating the guide that we are using during the insertion of the implant, and then later the same software that is used to choose the final abutment and the final restoration. In this case, we will put an implant in the missing tooth number 16. So what we do with the Artgate, first with ExoCAD, we do the mock-up, the position of the crown, where we want it to be, the ideal position of the crown. This case, I did it with my friends in Istanbul. I would like to thank them. Nuruddin Dergin, who is my close friend, he and his team helped me to do this work. But now I'm doing it in my own practice. So the intraoral scan, we transfer it into the software, and then we put the CBCT, 3D data, scanned data, X-ray data, the DICOM file, we transfer it inside the software, and we superimpose over each other, the intraoral scan and the CBCT. In this way, we will minimize the error, and in this way, we will be able to identify the position where we want to fix or we want to insert our implant. According to the dimensions available for us in the bone, we decide what diameter and what height of implant we need to use, and always keeping in mind the position of the crown or the position of the abutment that will hold the crown later. So here we are trying to finalize the position of the implant by respecting the biological limitations, that is the bone position and how much it is resorbed. We are making sure that the abutment is selected carefully and that it will be maximum at the center of the crown. Every detail in this planning counts. So this is minimizing chair time, because when we work carefully on the software, it will be very easy for us to transfer all the work done here inside the patient's mouth. So after adjusting or deciding where to put the implant, we have to create the guide. So how we do the guide, this is a special jig that is placed on the model, on the intraoral scan, Excuse me, I don't know why the movie is not showing. Anyway, here on R2Ware, we design the guide. We make sure that we don't have undercuts here at this area, at the gingival part of the crowns, in order to have a very passively fitting, but at the same time, very good fitting guide that will not move during operation. So here I will show you the video. Okay, so we fixed the guide. We made sure that it fits perfectly on the teeth without moving and without distortion. We make sure that the cooling system works very well. Now I think we will have a new design of guides where the cooling will be much better. So here we are preparing the site with the special drills, guided surgery drills. Now we changed the guide because the diameter of the implant is wide. So we need to have the second guide that has larger opening in order for us to be able to fix the implant properly. This is a special implant driver where the green part that you are seeing must come directly in contact with the opening on the buccal side of the guide. Here you can see the torque is more than 45. I'm fixing the implant. I prepared the gum. And then here I will fix the smart pack, Hostel smart pack. I covered the implant with a healing abutment, large healing abutment, in order to display the gingiva. And then after 5 minutes, we removed it and we fixed the provisional crown on top of it. We checked the contact, the occlusion. I adjusted the occlusion. Then I filled the gap with Teflon, sterile Teflon, and then covered with global composite and cured it. This is the X-ray taken after the surgery. So here is the last case. I will share it with you. It is again guided implant surgery. The lateral tooth number 22 is missing. Again, with the exocat, the planning, the mock-up, position of the crown. We adjusted the model, the virtual model that is. We make sure that everything is correct. Then we transfer the mock-up and we superimpose it on the CVCT in order to make sure that they are fitting 100%. There are 3 points that we have to make sure that the position of each tooth is placed accurately in the position in order to be able to make a perfect planning. Here again, we are trying to place or choose the perfect sized implant in its perfect position. Here we are trying to have the path of insertion a little bit palatally. In order to have screw retained temporary. So in this video, I hope this doesn't stop like the other one. Here, we identify the periphery of the guide, and then we remove the undercuts, and the computer itself suggests the guide that we want to do. These two rectangular parts, we put it on the occlusal or the fitting surface of the guide, and this opening will okay, the rectangular parts that I was talking about is for us to see through the opening of the rectangular opening, to see that the fitting of the guide is done perfectly on the teeth. Because if the guide is not fitted well on the teeth, we will have the wrong position of the implant. All the planning will go in vain. So here on the software, we are trying to reshape the gum. Here is the position of the implant. We are trying to form the temporary, the fitting surface, and the emergence profile of the temporary in order to have strong restoration, temporary restoration. And this is the surgery. We extracted the lateral, but it broke. I tried to remove it as much as possible automatically, but I was not able to. So I was obliged to open the flap, but unilateral flap. The vertical incision was done only from the distal side. So here are the drills used. Always on the guide, we put the name of the patient. So the implant insertion, after the drilling protocol is finished, we fix the implant in its place. We torque the implant. As I mentioned, this is the opening on the guide, the buccal opening of the guide or the labial opening of the guide, where the green lines must show in order to make sure that the position of the implant is right. After inserting the implant, we needed to do some modification for the bone, reshaping of the bone, to be able to put so here you are seeing that the provisional is broken. So sometimes bad things happen. So either we will do two provisionals or we will go back to our conventional technique. This was an accident, but it's good that it was done or it happened in my hands, because thankfully and good luck of the patient that I have with me my fuse abutments where I replaced them. So instead of using the provisional done by the CAD/CAM, I directly did the provisional on fuse abutment. As you will see, I finished the abutment and fixed it, cemented it, cleaned the cement, and we finished the restoration. So I hope some of you enjoyed, or all of you enjoyed the presentation. And I really appreciate your presence. Now, if you have any questions, I'm ready to answer them. Rolandas?
Yeah, I'm here. So thank you, Arthur, for your really brilliant presentation. As I see, we didn't receive any questions, but may I ask all of the attendees, maybe someone has to ask something, someone wants to comment on something or anything. So right now you're really able to do that. So if you would like to do that, so please don't hesitate and do it right now, because it's a brilliant time to have a live chat with Dr. Arthur. So either everything is really clear or either nobody understood anything. So, but I think everything was really clear to understand. So thanks a lot, Dr. Arthur, for your really brilliant presentations once again. And to all of the participants, so please catch up on all our webinars that you have missed on our official website, www.imegagen.com, and look out for the exciting new series, The Moment. So more information will come up soon. So thank you once more, Dr. Partiyan, for your time, and I hope to see you soon somewhere. Thank you all, guys, for staying with us. Also, stay safe, stay healthy. And I really would like to meet you somewhere in a near future.
Can I ask a question?
Yep.
Go ahead.
Dr. Partiyan, you did a lot of discussion about the fuse abutment, and you clearly use it as part of your everyday practice.
Yes.
Is there any cases where you don't think it's necessary?
Sorry, excuse me?
You use the fuse abutment a lot.
Yes.
Is there any case where you don't think it's necessary?
In 2 cases, I didn't use fuse abutment where I had more than 70 newtons stability. So one of the cases maybe you have seen before, and the other case, I loaded it in 2 weeks. My friend came from United States. I extracted the tooth. It was April 8, and April 23, I delivered the crown, and I provisionalized it. If you want, I can share the unprepared photos.
How long ago?
It was 2017.
So quite recent. Have you got a
Yeah.
follow-up of the other case?
2018, he came back. I have photos from 2018. 2019, he didn't come back, and now he will try to come back at the end of the year. But
Now he hates his tooth fell out. No, I'm joking, Artur. I'm joking.
No, it is very, very happy. Even his dentist, he didn't, there in LA, he didn't believe that in 2 weeks we loaded the implant, we extracted and reloaded it. So he's very good.
Cool. Okay, good. It was really interesting to see so many cases, because I think you're the one of not so many doctors that understand the advantage of this kind of abutment. So
Yeah.
really nice to see your presentation from that point of view.
Thank you very much, Tom. Nice to see you too.
I'm done. I won't ask another question, Rolandas.
No, everyone's free to go. So. Go, everyone, go. All right, so once again, Arthur, thank you so much for your time. Thank you so much for the cases. And see you somewhere soon, I hope, okay? So stay safe and healthy, and bye, everyone.
Bye.
Yeah.